everyone, welcome to my channel. In today's video, I'm going to discuss about a very important topic, that is how to write an assessment format through SOAP protocol, that is subjective, objective, assessment and plan of care protocol. Now this is a very important topic for your third year and also for your final year physiotherapy curriculum. So without getting any delayed, let's get started. Now, before we get to the main part of the video, here are some points to ponder. SOAP notes is one of the mostly used POMR, that is problem-oriented medical record. It is a sequential method which is organized, comprehensive and reproducible. A musculoskeletal assessment requires a proper and thorough systematic examination of the patient. The examiner must look at the joint and injury in the context of how the injury may affect other joints in the kinematic chain. Okay, now under SOAP format, first is your subjective details. Under this, first comes your demographic data or demographic details. Under this, you should first write your name. Name indicates patient's own identity. Rather than calling him or her as a random patient, it gives a morale and psychological boost for the patient. It is also necessary for documentation purposes. Second is age. Age is helpful to diagnose the patient's condition. Example, various growth disorders like Lake-Perthes disease or Scarsman's disease are seen in adolescents and teenagers, whereas degenerative conditions like osteoarthritis and osteoporosis are more likely to be seen in an older population. Third comes your sex. Sex is also having a diagnostic value. Like in prostate cancer, it is commonly seen in male, whereas breast cancer is common in female. Another example, like osteoporosis, osteoarthritis, these degenerative conditions are less common in premenopausal female due to the protective effect of estrogen, whereas it is not for the case of a male. Fourth is your address. Address gives an idea about patient's condition's dominancy. Like suppose a patient belonging to a particular area which is prone to malaria comes to you with symptoms of malaria, then it will be easier for you to diagnose that the disease might be or possibly be malaria. Fifth comes your occupation. A working conditions help to determine the problem. Now suppose a desk job worker is commonly prone to neck and back pain, whereas a laborer is more prone to develop problem from their work condition. Sixth is your dominant side, that is either the patient is left-sided or right-sided dominant. Now why it is important? Suppose if the injury or complaint affects the dominant side, then it is necessary to make the non-affected side efficient, because if we don't do that, then the patient cannot compensate the daily life activities with the non-involved limb. It is also used for vocational training. Seventh comes your hospital number. Now it is a unique number for every patient. It helps in record keeping. Every information is gathered with the previous information. Eighth is your date of admission. It is the date when the patient admits to the hospital. Ninth comes your referral. Special medical facility when not available, medical institutions can refer to another institute with specialization on that condition. Now this concludes the demographic data or demographic details. Now comes your chief complaints. It is the main problem or problems faced by the patient when admitted to the hospital. It is patient's own words what the patient is unable to do functionally. medical terminologies are not used here. Chronological order is maintained. As an example, you can write unable to use left upper extremity because of severe weakness and restricted functional activities for last 4 months. Another example, pain present in forearm and hand region for last 4 years. Okay, now comes your history taking. This means the events took place from starting of the condition till present. Under this, first is your history of present illness. It describes patient's condition in chronological order. Then comes your history of past illness. Now it is not a necessary one, but if the patient is met with same conditions earlier, then it is important. Then comes your medical history. If the patient is taking medications for previous surgeries or any other condition, then it is very much important. Medicines like analgesics, steroids, etc. should be reported, because long-term anticoagulant therapy or long-term steroid therapy may lead to hemarthrosis or osteoporosis respectively. Then comes your surgical history. Now this is important because from surgery a specific group of muscles or specific muscles are incised and they get weakened, and having a sound knowledge of that will gives you a benefit when you are treating the patient after the operation or post-operative rehabilitation. Then comes your socio-economic history. Under this, you get to know the social status, the education of the patient, and also you get to know if the patient is the only earning member of the family. All these information are important to know if the patient can afford the therapy and the devices required for him. Then comes your environmental history. This gives you an idea about the condition of the environment the patient lives in. Then comes your pain history. Now this is the most important history in my opinion, and we are going to discuss it in the next slide. Okay, now comes your pain history. I have a short mnemonics for you guys, and that is old cards. So the first is the onset of the pain, that is if the pain is sudden or gradual. Then the location of the pain. In this, either the pain is a localized pain or a centralized pain. In localized pain, the pain is mostly due to the damaged tissue, inflammation, or peripheral sensitization of nociceptors, that is primary hyperalgesia. And for centralized pain, injury doesn't go through a normal healing pathway and becomes chronic, involving the spinal cord and the brain. Then comes your duration. Now for acute pain, the duration is around 7 to 10 days. For subacute pain, the pain duration is around 10 days to 7 weeks, and for chronic it is greater than 7 weeks. Now acute pain is more accompanied by anxiety, whereas chronic pain is more accompanied by depression. In acute condition, pain is severe, which restricts any movement. It bars the therapist to do a full evaluation. Now, if the patient is protecting the injured area, it indicates patient is in discomfort and fear of pain. Then comes your character of the pain. There are mainly 4 types of pain or 4 characters of pain. First is your cramping, dull aching pain. These are mostly due to muscle, ligament and joint capsule involvement. Then comes your sharp, bright and lightning pain. This is mostly due to the involvement of nerve. Then comes your sharp, severe and intolerable pain, which is mainly due to fracture. Then comes your throbbing or diffuse pain, which is mainly due to vessel involvement or vasculature pain. Then is your alleviating factor or the factors which relieves the pain. Then comes your radiation, or if the pain is radiating to another area other than the origin. Now here referred pain is also a point. Referred pain tend to be felt deeply. Its boundaries are indistinct and it is a radiation pain. It radiates segmentally without crossing the midline. Then comes the temporal pattern or the timing, like if the pain is increasing at the daytime or at night time, like that. Then comes your severity intensity scale. An increase in pain, that means condition is getting worse. A decrease in pain, that means condition is getting improved. That's all under your pain history. Okay, so in SOAP format, the second one is the O, that is objective assessment. Under this comes your on observation. So I have prepared a short mnemonics for you guys, and that is SWIFT. So S is you have to look for scars. W means you have to look for wasting of muscles. I, that is involuntary movements. F, fasciculations. T, tremor. I have also described this part in more details in the next slides, but if you remember this only, it's also good. Okay, so to know more details, what else you can observe from a patient are, first is your body build. That is either the patient is ectomorphic, mesomorphic or endomorphic. Then comes your mode of ambulation. That is if the patient is using any assistive aids like wheelchair, stretcher, etc. Then comes your external appliances or devices. It is generally ICU related, or like if there is a catheter, there is an orthosis, etc. Then the attitude of the limb and face, anatomic position of limb with respect to environment, facial asymmetry. Then comes your posture. You have to see the posture in anterior, posterior and lateral view. Then comes your involuntary movement. You have to check involuntary movement in your limb, finger, trunk or face. Then comes your muscle wasting. Then skin condition. Under this you have to look for texture, color and continuity of the skin. Then comes your wound or ulcer. You have to check for pressure sore, scar, etc. Then swelling or edema. You have to check if there is any swelling or edema in the patient complaint area. Then there is deformity. Under this you can check if there is any subluxation or LLD like leg length discrepancy. Then there is gait, type of gait pattern, the gait used by the patient. So now I have to palpate the area. So on palpation we are going to note the warmth of the area, if there is any tenderness present, if there is any edema, spasm, peripheral pulsation of that area. There are jugular pulse, brachial pulse, radial pulse, femoral pulse, dorsalis pedis and posterior tibial. Then you have to look for the contour of the joint, that is anatomical landmark related to any joint arrangement. Then you have to look for scar assessment from the site, nature and length of the scar. Then you have to look for if there is any wasting of muscle. Then you have to look for crepitus and muscular gap if any. And lastly you have to see for the bone condition, right? Now you have to look for vital signs. Under this you mainly have to check three things. First is your blood pressure, that is BP. Then is your heart rate or HR. Then is your respiratory rate or RR. Other than this you can also look for temperature, pain, BMI or basal metabolic index, cyanosis and clubbing. Okay, now the third part of the SOAP protocol is the A or the assessment plan. Now under this comes your on examination. So first you have to look for the higher mental function. Under this will come your orientation, vision, hearing and memory. So all this you can check with your simple questionnaire, that is MMSE or mini mental state examination. Then will come your cranial nerve examination. I'm going to make another separate video on this topic, but for now you can check a Sullivan book to know how to examine cranial nerves. Then will be your sensory examination. Under this, first is your superficial senses, that is pain, temperature, light touch and pressure. Then your deep senses, that is proprioception, kinesthesia and vibration. And lastly is your combined cortical senses, that is stereognosis, 2-point discrimination, tactile localization, barognosis, graphesthesia, recognition of texture, diable simultaneous stimulation. You can do a Ayrshire scale for the sensory examination also. Okay, now I have to check for the reflex examination. Under this, the superficial reflexes, which are corneal, pupillary, gag, abdominal, cremasteric and plantar reflex. Then will come your deep reflexes, which are biceps, triceps, supinator, knee and ankle reflex. Then the motor examination part. Under this, first you have to check the tone of the muscle, which is very important, because if the tone is normal, then you can further assess the patient, and if the tone is not normal, that is if the patient tone is either hyper or hypo, then you cannot check the strength of the muscle. The second thing you have to look for is the range of motion. Under this, there is active range of motion and passive range of motion. So active range of motion is the range of motion done by the patient, and the passive range of motion is basically done by the therapist. Then will come your strength. Three things, right? First is the MMT, that is the manual muscle tester, which is mostly used. Then the RIC or Siriach's principle. RIC is basically resistance isometric contraction, which you know. You have to take the muscle in mid-range and you have to give the resistance and all that, and you get the idea about the strength of the muscle. And then is your VMC, that is voluntary muscle control. It is generally used for stroke patients, right? Then there is synergy, or the pattern of movement. Okay, so now there is joint mobility. You can check under motor examination. Then will come your test movement. It is basically the McKenzie concept and related to spinal mechanical disorder. Then coordination. Under this, you have to check the coordination of the patient, which includes finger to finger test, finger to nose, Mars grasp, finger to therapist finger, heel on shin, etc. There are lots of things you can check on coordination, and I'm going to make further detailed video on this, but for now you can only check all this, but you can also check the Sullivan book for further details. Then you have to check the balance. Under this, there is static balance, or when the patient is basically static, then how you can maintain the balance. And there is dynamic balance, or the patient is now moving and you have to check the balance on that movement. You can do perturbation to check. Okay, now you have to check for functional evaluation. Under this, first you have to check the bed mobility, that is like supine to side lying and then to prone lying, or supine to sit, etc. so on. Mat activities, you have to check the rolling, bridging, prone lying with forearm support, sitting, hitching and hiking, all that. The third is your functional transitions, that is getting down to floor, side setting, prone kneeling, crawling, kneeling and half kneeling, getting up the floor, etc. Then is your functional evolution. So all this functional evolution part, if you want to know more about this, you can follow the Dina Gardiner book or the Gauri Shankar assessment book to get a more detailed idea about all this, how to do and all the, because there are more pictures, right? There are more pictures. Okay, now the second is your special test. Okay, if there is any special test that you think is required, then you can include in this part. Then the gait analysis, that is how the patient walks. If there is any deformity, then you note that, and along with all the components, his stance and swing pace. Then is your tightness, contraction and deformity, which is more common in neuro cases. So you have to find which muscle is basically tight and if there is any contracture due to that tightness, and ultimately in neglected cases if there is any deformity. And then there is the radiological assessment. So with respect to, there is X-ray, CT, MRI and ultrasound. So you'll get to know all this from this radiological assessment. Okay, then you can take measurements for upper limb. The measurements are, first is the circumference of middle of the arm, circumference forearm, 1 inch, 2 inch and 3 inch from external epicondyle, from acromial process to tip of the styloid of radius, from acromial process to lateral epicondyle, from lateral epicondyle to tip of styloid of radius. And for trunk, there is inspiration movement, expiration, Lenny's test. And for lower limb, there is umbilicus to ASIS, circumference of mid calf, circumference of mid thigh, ASIS to medial malleolus, umbilicus to internal malleolus, ASIS to adductor tubercle, upper end of tibia to internal malleolus, intermalleolar distance. Now comes your problem list. This is basically the problems faced by the patient. Okay, so you have to mention all the problems in like point wise, then you get an idea what are the problems facing by the patient. This problem list was also helpful when you are not attending the patient and some other therapist, because he will get an idea about what the problems the patient is facing, so the rehabilitation is also very easy. Okay, now is your plan of care. Under this, first is your short-term goal. So this is basically the goal you are looking for to achieve like in first 1 or 2 weeks, right? And then is your long-term goal, which is, you know, like the permanent goal you are thinking from the beginning, but it will take a long time, so it is a long-term goal. So now suppose a patient of frozen shoulder comes to you. For that patient, the short-term goal would be like, you know, relief of the pain, and the long-term goal should be the increase in range of motion, so the patient can do the functional activities more easily. Now comes your reevaluation. This is basically evaluating the patient once again after a certain period of time. This will give an idea about the current condition of the patient. If your therapy is working, then there is progression in the patient condition, or if it is not working, or if it is harming the patient, then it will regress the patient condition. So basically you will get an idea about your therapy, your treatment, and the patient will also get an idea if there is an improvement or not. Now is your discharge planning. That is, patient is now well and good, patient can do all the things of his own. Now you're planning to discharge the patient, you have to mention the date and all that, and how the patient has improved. All this you have to note in your discharge planning, right? And yeah, that's all, and that concludes your assessment part, right? Okay, so that's all for this video. I hope you like the video, and if you do, then please like, share and subscribe to my channel. And I am also going to upload the note of this assessment plan in my Telegram channel, so the link will be given in the description box below, so you can follow the channel to get my notes and in all detailed manner. And thank you so much, guys. Please keep watching the video and please keep supporting the channel. Thank you, guys. Thank you.